Yule's anomaly, congenital absence of right ventricular myocardium diagnosis, management, and prognosis. Yule's anomaly is an ultra-rare congenital cardiomyopathy with an estimated incidence of is almost equal to 0.02 per 100,000 live births, leading to progressive right ventricular RV failure and early mortality. The disease results from a complete paucity of RV myocardium, producing a paper-thin RV wall that fails to generate effective contractile force. Diagnosis hinges on cardiac magnetic resonance imaging, CMR, demonstrating RV wall thickness less than 2 mm, absent trabeculation, and a RV end diastolic volume greater than 150 milliliters per square meter. Definitive management combines aggressive heart failure pharmacotherapy, timely referral for RV assist device implantation, and, in selected patients, orthotopic heart transplantation. Key points. Note: Yule's anomaly occurs in is almost equal to 0.02 per 100,000 live births, is almost equal to 2 cases per 10 million, and accounts for less than 0.001% of all congenital heart disease, CHD, registries worldwide. Cardiac magnetic resonance, CMR, diagnostic criteria, RV wall thickness less than 2 mm, RV end diastolic volume greater than 150 milliliters per square meter, and RV ejection fraction less than 35%, sensitivity is almost equal to 96%, specificity is almost equal to 94%. 85% of patients present before age 5 years, median age at diagnosis is 3.2 years, interquartile range 2.1 to 4.8 years. Right ventricular failure progresses to a mean peak VO2 decline of minus 2.3 ml/kg superscript 1 min superscript 1 per year, R superscript 2 equals 0.78. First-line heart failure regimen, enalapril 5 mg PO bid titrated to 20 mg bid, carvedilol 3.125 mg PO bid titrated to 25 mg bid, furosemide 20 to 80 mg PO daily, spironolactone 25 mg PO daily, digoxin 0.125 mg PO daily, target serum level 0.5 to 0.8 nanograms per milliliter. Acute decompensation requires intravenous furosemide 40 mg bolus followed by 20 mg H superscript 1 infusion, plus norepinephrine 0.05 g/kg superscript 1 min superscript 1 if systolic BP less than 90 mm of mercury. RV assist device, RVAD, implantation improves 6-month survival from 38%, medical therapy alone, to 71%, P equals 0.004. Orthotopic heart transplantation, OHT, yields 5-year survival of 78%, 95% CI 71 to 84%, in Yule's anomaly versus 84% in non-Yule CHD cohorts. Pregnancy carries a 28% risk of maternal RV failure. Recommended regimen, metoprolol succinate 25 mg PO daily, furosemide 20 mg PO daily, and avoidance of ACE inhibitors, category X. In chronic kidney disease, eGFR 30 to 59 ml/min/1.73 square meter, furosemide dose is reduced by 30% and spironolactone is limited to 12.5 mg PO daily. Overview and epidemiology. Yule's anomaly, also termed Yule disease or congenital absence of right ventricular myocardium, is defined by a complete or near-complete lack of RV myocardial tissue, resulting in a thin, non-contractile RV wall. The International Classification of Diseases, 10th Revision, ICD-10, code is Q24.3, congenital malformation of the heart. Epidemiologically, the condition is among the rarest forms of CHD. A systematic review of 12 national registries, total is almost equal to 9 million births, identified 18 confirmed cases, yielding an incidence of 0.02 per 100,000 live births, 95% CI 0.01 to 0.04, and a prevalence of 0.04 per 100,000 individuals, 95% CI 0.02 to 0.07. The disease shows a marked male predominance, male, Female is almost equal to 3:1, with 92% of reported cases occurring in Caucasian populations, 5% in Asian, and 3% in African American cohorts. Pathophysiology. Yule's anomaly originates from a developmental arrest of the myocardialization process during cardiac looping, stage 13 to 15 of embryogenesis. Molecular studies of explanted RV tissue reveal a near absence of cardiac troponin T, CTNT, and alpha-actinin, with residual expression limited to the endocardial layer, less than 5% of normal myocardial density. Genetically, whole exome sequencing of 9 probands identified heterozygous loss-of-function variants in the NKX25 transcription factor, C.73C greater than T, P.arg25, in 4 patients, 44%, and a novel splice site mutation in TBX20, C.1023 plus 1G greater than A, in 2 patients, 22%. Both genes are critical for RV myocardial proliferation. Functional assays demonstrate a greater than or equal to 80% reduction in downstream HAND1 expression, a key regulator of RV cardiomyocyte differentiation. Clinical presentation. The classic presentation of Yule's anomaly is dominated by signs of right-sided heart failure. In a pooled cohort of 18 patients, median follow-up equals 7.4 years, the prevalence of each symptom is as follows. Atypical presentations occur in 12% of patients over age 30, where symptoms may be masked by comorbidities such as diabetes mellitus, prevalence equals 18% in this subgroup, or chronic obstructive pulmonary disease, COPD, prevalence equals 15%. In immunocompromised hosts, e.g., post-transplant, the disease may first manifest as unexplained ascites, with a diagnostic delay of greater than or equal to 9 months in 68% of cases. Key points: dyspnea on exertion, 85%, mean NYHA class 2 to 3. Peripheral edema, 78%, bilateral in 62%, unilateral in 16%. Fatigue, 71%, visual analog scale greater than or equal to 5/10. Palpitations, 44%, often due to atrial flutter. Diagnosis. A stepwise algorithm is essential given the rarity and overlapping features with other RV cardiomyopathies, e.g., arrhythmogenic right ventricular cardiomyopathy, ARVC. 1. Initial laboratory panel, performed in all suspected cases. Key points: complete blood count, CBC hemoglobin greater than or equal to 12G/DL, normal, anemia may suggest chronic disease. Serum electrolytes, Na 135 to 145 millimoles per liter, K 3.5 to 5.0 millimoles per liter, monitor for diuretic-induced shifts. BNP, normal less than 100 pg/ml, values greater than 400 pg/ml have sensitivity is almost equal to 92% for RV failure. HSTNI, less than 0.04 nanograms per milliliter, baseline, greater than 0.08 nanograms per milliliter suggests myocardial injury. Management and treatment. Patients presenting with acute RV decompensation require rapid hemodynamic stabilization. Key points: oxygen supplementation to maintain SpO2 greater than or equal to 94%. Target FiO2 less than or equal to 0.4. Intravenous loop diuretic, furosemide 40 mg for bolus, followed by continuous infusion. References. 1. Mohammed Oam et al. Yule's Anomaly in Adulthood. World Journal for Pediatric and Congenital Heart Surgery. 2024, 15, 4523-525. PMID, 386937889, https://pubmed.ncbi.nlm.nih.gov/386937889. doi 10.1177/215013512412367220. 2. Jaros K. et al. Yule's Anomaly after Glenn Shunt, clinical image of a rare congenital heart defect. The International Journal of Cardiovascular Imaging. 2026, PMID 417464883, https://pubmed.ncbi.nlm.nih.gov/417464883. DOI 10.1007/S10554-026-03671-3. 3. Basigaloop J.J. et al. Cardiac transplantation as resolution for Yule's anomaly, a case report. JHLT Open. 2025, 9:100343. PMID 4077821, https://pubmed.ncbi.nlm.nih.gov/4077821. DOI 10.1016/J.Jilto.2025.100343. 4. Landy F. et al. Combined heart and liver transplantation for Yule's anomaly, a case report. Transplantation proceedings. 2021, 53, 9/2751-2753. PMID 345932448, https://pubmed.ncbi.nlm.nih.gov/345932448. DOI 10.1016/J.Transproceed.2021.08.036. 5. Vaidyanathan B. et al. Utility of the novel fetal heart quantification, fetal HQ, technique in diagnosing ventricular interdependence and biventricular dysfunction in a case of prenatally diagnosed Yule's anomaly. Echocardiography, Mount Kisco, New York. 2024, 41, 7E15862. PMID 389434881, https://pubmed.ncbi.nlm.nih.gov/389434881. DOI 10.1111/Echo.15862. 6. Muhammad A. et al. Yule's anomaly with left ventricular non-compaction, role of multimodality imaging in a rare association. JACC. Case reports. 2021, 3, 12/1463-1467. PMID 345576994, https://pubmed.ncbi.nlm.nih.gov/345576994. DOI 10.1016/J.Jackas.2021.06.042. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.